Welcome back, and thank you for staying with KTN Prime. And of course, it's this particular moment that we get to have a sit down, a conversation with Dr. Deborah Barasa, the CS Health in this country. Good evening, and thank you so much for making time for us. It's good to have you back, actually.
Thank you, Ashley, for having me. Thank you.
Anytime, Karibu. So let's start with the recent issues that are happening in the country. Just yesterday, you signed a return to work formula with the clinical officers. Some good news there, ending that strike. But here we are again, another strike looms as doctors and civil servants have threatened to take to the streets come March 18th. What are you doing to avert this?
Yes, you know, Ashley, dialogue is really critical. Open dialogue, listening and ensuring that you have interventions coming in as fast as possible. Yeah. And that is actually one of the lessons we've learned from the clinical officers. And so we are really engaging the teams, you know, the SGs and everyone to ensure that we are addressing their issues. So we are very happy with the clinical officers. Now they are offering services in the various healthcare facilities. And that is quite a big gain for us as a ministry, because we need the human resource for health when to serve the people of Kenya. So right now, even with the medical interns, we are engaging them, the civil servants, and what we want to tell them is we are working as fast as possible to ensure that we have a scheme, a medical scheme, that is the public officers medical scheme for the civil servants, and also addressing the medical interns grievances.
Okay, correct me if I'm wrong. The Public Officers Medical Fund was established in 2012 when the civil servants forfeited their medical allowance for insurance scheme. Like many are saying, they're contributing double for SHA and for the fund. Why is that?
Now, for SHA, what SHA is about universal health coverage. It is like the bare minimum that each one of us needs to have. Suppose you lose your job here, Ashley, what are you going to use? SHA will be there for you. So it's a universal health coverage. And you can see from the benefit package, there's quite an enhanced benefit package when you compare to NHIF. And really, this is what, as a country, we need to focus on and move forward to ensure that SHA works. Because when SHA works, then our health insurance as a country is going to be good. Any one of us can access the care, that universal health coverage, you see. So what we are encouraging Kenyans, let us all register. When we all register, when we all contribute, then there is no need even to have those parallel or fragmented medical schemes. So yes, we are working on the public officers medical scheme, but what we are saying that critical to us, all of us, whether you're rich, whether you're poor, you know, you have a job or you don't have a job, you know, whatever kind of background you're coming from, SHA and Taifa Care is what will work for all of us. And really the message is that let us all register and contribute so that we can be able to access care.
So then, is there a timeline in ironing out these issues? Because next week is just a few days away.
Yes, yes, we are working towards that. And what we have done, we've allocated some resources to support the scheme. So you know, for the police officers, they were under another scheme. That was the private practitioners medical administrator. That was, the medical administrators Kenya Limited scheme, which is by a private practitioner. They were not under NHIF for a whole 2 years. And now what we are telling them, they need to register for SHA. If they register for SHA, they can access healthcare services like any other Kenyan. Then after that, then there's the top-up from their medical scheme that they have. So ultimately, SHA is the way to go. We are talking about medical students or interns out there who don't have a job. They can be able to access this very same care. And I remember myself being an intern. I remember being, you know, a postgraduate student. You could offer the services, but the very services that you're offering, you can't afford.
Okay.
Yes.
And we'll talk about SHA in length. But, you know, the unions are claiming that the move to deny public servants medical cover is a deliberate effort to undermine the workers' welfare. Is this the case? Because then where is their money going?
Absolutely not. That is not the case. We are working towards it, and you know, these are actually, maybe we will have the public servants, the group coming here to discuss that. But as a ministry, we are supporting them to have a medical scheme. But you know, the thing is, Kenyans are not getting. Social Health Authority is universal health coverage. It is for all of us. Whether you have a job or you don't have a job, it's for all of us. So why not have the bare minimum, which is SHA?
CS, allow me to interject. Their issue here is that they're having double deductions and they're not getting value for their money. So it's not even about SHA, it's about value for your money when it comes to healthcare services.
Yes, so what I'm telling you is that we are working towards having the medical scheme. We have been able to allocate resources. Yeah, the public service has been able to allocate resources, and we have a scheme they are working. Yes.
All right, so let's now talk about SHA. So majority of Kenyans claim that SHA is not working for them. The government insists SHA is working. From where you sit as the CS, if SHA is working, what exactly is working in SHA for you?
All right. Now I'll start from NHIF. When you look at NHIF, there was accrual of debt for many years, and actually they were anticipating that it would crash in 2022. So we were going nowhere. It was actually plummeting, and the debt had accrued to 30 billion, okay? So now NHIF was really not the way to go, and everyone knew it, but no one was out to call it. Secondly, when you look at NHIF, the administrative costs were at 37%, yeah? So meaning the contribution of Kenyans, 37% of it went for administration, and then the rest would go for service to the people. When you look at SHA, only 5%. So meaning there's more money for health service delivery for Kenyans. Another thing is the false claims, okay? So what we saw in NHIF, there were multiple false claims. I can give an example of a leg being amputated 5 times, you see? Or a mother delivering 50 times in a year. So there were a lot of false claims that were coming up, yeah? And again, that one was a way of corruption. And what we are doing for SHA is that we are ensuring that we have a digital platform. And in this digital platform, we continue to enhance it so that these inefficiencies, this corruption that was occurring, we are able to address exhaustively. And one of the ways you can see is transparency and accountability. When you look at the site, you're able to see that we have printed all the facilities, how much they've been able to receive up till now, okay? So if anyone has a concern, then they can raise their grievance. There's a link where you can click and you're able to see what are the concerns, yeah? Because what we notice is some private facilities, okay, were complaining that they have not received any money, but yet there were errors. There were errors in terms of the name of the facility or the account, okay? So what we are saying is that it is open. In fact, right now, when you listen to private facilities, they are concerned. They're like, now when you're exposing us of how much we've paid, people will start asking for raise, you know? And thirdly, when you look at NHIF, it had multiple schemes. Now, for the multiple schemes, you will notice that for the civil servants, they were getting a better deal, okay? So they could travel, abroad for services, etc., at the expense of the ordinary Kenyan, whose amount was limited, right? And in some private facilities, it could only pay for a bed. Now, when you look again at SHA, you see that there's enhanced health package. We have now mental health, we have oncology services, and we have dialysis services that have been expanded. We have critical care services like ICU, which was not there under NHIF. So there's enhanced package. Again, the vendors who are causing corruption and digitization is helping. And again, fictitious facilities. There were some facilities which were non-existent. There was a one-room facility that would claim for ICU beds of 50, okay, or that could claim for dialysis, And a critical thing that I need to talk about is the primary health care. In this kind of a scheme, what we are strengthening is the primary health care facilities. Why is that? Long time ago, you remember, okay, maybe you were not born, but we used to go.
Not as young as you think, but okay.
So we used to go to health centers and dispensaries, and medicine was there.
Yeah.
But right now, what's the norm? Everyone assumes that the health centers, dispensaries have nothing. Everyone has now, flooded the level 5 and level 6. What we want to do is to revive the primary healthcare facilities. Yesterday, when we were with the meeting with the Council of Governors on USG funding, I remember, Honorable Waiguru was looking and saying, oh my goodness, you mean my health center has gotten all this money? Why should it get all this money? I expect this to be at the higher levels of care.
Okay.
But what we are saying, we want to capacitate the primary health care so that right at the door, close to your home, close to your neighbor, you should be able to access those very services. And then now for level 5 and 6, those are the referral, the patients who have complicated. Okay. And again, capacitating the public facilities so that we can improve the services for all patients.
Allow me to just recap so that I'm sure that I got you right. You said NHIF went down because there were 30 billion shillings in debt, right?
Yes.
Here we are, we have spent 104.8 billion shillings on a system. You claim that the multiple schemes were in NHIF, and here we have enhanced health packages on SHA. Why not? Because if you're using 104.8 billion, yet on this other hand, you had 30 billion, the math is not making sense. If there were all these schemes and all these issues, why not streamline rather than come up with a new scheme altogether?
Okay. So first of all, you should understand that NHIF scheme was corrupted, all right? So there were people who could be able to hack in and make some crazy, transactions or remove money from the system, all right? So it was not stable. It had people who had learned and understood the system. And you can talk to a few doctors and you'll really listen and understand what they are saying. Because what someone would have to do, a healthcare worker, is just, talk to someone who's inside the NHIF and tell them, or maybe the one who's inside is saying, let me send you 200 million, give me my 20 million, and then try and figure out the accounts.
So why not clean up the mess then?
And so when you look at this system, it is the digital health superhighway. It has multiple components with the health information exchange system. One of them being the patient, the patient portal that will look at the patient journey. Once the patient enters the room, once they take their vitals, you can always have a chart of their vitals. And again, you'll have the examination, what medications they've been given, and then the claim goes to social health authority. So you can see the patient's journey. And this is historical, you see? And then you can use the same, it's interoperable. So you can use it in any facility, in any county. So you don't need to carry all those things. Secondly, it has the health workers register. So we need to ensure that all health workers are licensed, okay? So that improves quality. Again, it has medications, okay? And again, the healthcare facilities, ensuring that each one of them has been assessed, okay? And, and is capacitated on that level of care,
okay.
All right? And again, it has the ICHIS, which is the, community health information system, all integrated. Again, surveillance, At times you may have an outbreak. How fast can you pick it? You can have, right now there was recently a diarrheal disease in Kisii. We need to pick these things promptly as
I don't know,
health
CS,
experts.
once again, if I may cut you short.
Yes.
Have you interacted, perhaps you were not feeling well just the other day, last week. Did you interact with this SHA? Did you experience the delays that, normal Kenyans do experience?
Yes, and let me tell you something, Ashley. Delays can occur. Even when you look at the systems, the finest systems in UK and US, yourself, even when you have your mobile banking, there's some delay.
But this
there's
is
some
your
internet.
life you're talking about.
And so what we are saying, if the system is not working, we're not saying health service provision is stopped because of a system. No, not at all. You can use hard copies. You can also have the information out there, and then you can put it in once the system is up. So we are saying no Kenyan should be denied health services because of a system. But this system must work. You know why? Because once the system works, then we'll be able to avert corruption in the country. And seeing that it was a nationwide, rollout, and again, seeing that the systems, again, as I said, you can have interruption. And it's not unique. Even for systems that have been there for many years, there's a time when they tell you, please, you know, wait for a few hours, we are going to configure, we are going to work on it, etc. Because you need to build it up.
Okay.
Yes.
I want us to listen to Honorable Mutula Kilonzo Jr. Yesterday you were in a meeting,
yes,
and this is exactly what he had to say. Let's just listen in.
Allow me to say this, Waziri, in your presence. And if I don't say this, I won't sleep well at night. Kenyans are suffering. SHA is not working. Kenyans are complaining. So to Moses Kuria, when you write your advice, just say, from me, that Kenyans are unhappy. Very unhappy about these medical schemes. They are not working as they should.
This is yesterday. You were in that particular
Absolutely,
meeting.
yes, I was.
For Kenyans, it seems that for the government, it seems aloof to the problems that Kenyans are facing. Here we are, this is the 6th month down the line. It's no longer teething problems. These are problems that are affecting Kenyans who are seeking health services. It seems that the government is hell-bent on saying that a system is working, yet Kenyans are saying it's not working.
Okay. Now, you know, when after Mutula talked like that, I went and sat next to him and I asked him, have you seen the digital platform? Have you seen the dashboard? And he said, okay, this is my phone. Please set it up for me. And so I called one of the CEO for Digital Health Authority, and he was able to set up. Now, the governor saw that his county, Makueni County, had actually received 749 million Kenyan shillings. And he was perturbed. He was like, what do you mean? You mean I've been receiving all this money and I don't know? Now, what we are asking, if he's been able to receive this money and he is not informed, suppose he registers patients. What does that mean? That money is not remaining at national level. It's trickling down to your county, to your facility. And what you require is just to register and see patients under SHA. So if he is not aware of what his county has, suppose he becomes a SHA champion. That means more resources at county level, more human resource, more health products, more commodities, more equipment, CT scan, etc. And now you become a specialized facility, and you're able to see all these cases seamlessly.
How
so
many
now
people
what we are
have
saying,
registered for SHA?
We've had, when you look at NHIF first, it's 8 million. Now under SHA, we have more than 20 million Kenyans.
How many
So
people
when
are
we
actively
think,
contributing?
Okay, now I will answer. That's a brilliant question. First of all, you have to see that there is accessibility in terms of, number one, the numbers. Number two, facilities have expanded. Number three, geographical expansion. All the counties, unlike NHIF, which had selected, and it was actually private facilities that were benefiting.
You're still not answering
Let
my
me
question.
now answer your question. Now, when you look at those that have registered under SHA, they are over 20 million, right? Meaning they can access primary health care under the primary health care fund, which is from the exchequer, that is from National Treasury, meaning all Kenyans can access this. Among those 20 million, 4.4 million Kenyans have contributed, and they are able to access the Social Health Insurance Fund. So then, now, let me answer about your sustainability. When you look at, I said number one, NHIF had accrued a lot of debt up to 30 billion Kenyan shillings. Now, come to SHA. When you look at SHA, what we have, people have, the 4.4 million Kenyans have contributed 6.7 billion Kenyan shillings. The claims are worth 4 billion Kenyan shillings, meaning we have a surplus of 2.7 billion Kenyan shillings of the 4.4 million. How much more when we have all Kenyans on board?
But the system relies heavily on member contribution, right?
The Social Health Insurance Fund, yes. But right now, we are not facing any crisis. We have a surplus of 2.7 billion Kenyan shillings, meaning if all Kenyans are on board, then we'll be able to change our health system. And we will not be dependent on USG for funding and other things. We need to be self-reliant.
Yes. All right.
We need to be self-reliant. Yes.
So then, from everything that we have canvassed right now up until this point,
yes,
are Kenyans justified about being disgruntled on this particular system? Because you can have a brilliant system, you can have money, you can have contribution, but if services are not reaching to the common mwananchi, what's
services are reaching, we have not interrupted in, you cannot interrupt services because of a system, really. A system is a system. Services continue. The doctor is there, the nurse is there, they see the patient, and services continue.
Okay.
We cannot deny services because someone has not received their OTP. But what I'm saying, the system has the minimum viable product. That was what they had promised us at the beginning of the few months. Now they are expanding it. So I am confident because the system has been implemented in other countries with great success.
okay?
Okay, so following the same pattern that we are using. And so we are confident. This is the way to go. All the countries are going. Everyone is talking about UHC. Yeah, and I think the donor fund, the USG funding withdrawal was an eye-opener for us. Do you know what we need to do, Ashley? We just need to plug in the HIV program into the broader health system. That is the UHC. What does that mean? We take our primary health care fund and incorporate funds for commodities for HIV, for malaria, for TB, etc. And then patients contribute under the social health insurance fund when they are complicated, you see?
Okay.
So it's really just plug and play for all these health programs that we have in Kenya. Okay. So ultimately, it's just one system that should work.
All right, the Auditor General's report
Yes.
did unearth a number of irregularities when it comes to that digitization system. So my first question then is, do we have control over that system?
Yes, actually we had this discussion, and what I told you in matters accounting, what I can assure you, we'll have a comprehensive discussion next Thursday. I'm going to call my PS, Medical Services, so that he can give you response for all the questions that you have on the Auditor General, because he had a comprehensive report. There were deliberations as well done within the ministry, and he should be able to answer those.
But at the end of the day, you are the authority in the Ministry of Health. You
Yes.
should be able to answer these questions, even as we wait for that comprehensive report.
Yes.
So then, do we own that system?
Ashley.
Do we have
Yes.
control over it?
Yes, we have control. We are able to review the system. We are working together and collaborating to ensure that the system is functioning to the last mile. Yes.
Let me just quote the Auditor General's response towards that. Unfavorable contract clauses. For instance, the contract says the government cannot access or control the system. I quote, the procuring entity shall ensure neither the procuring entity nor the government health agencies nor the procuring entity authorized users shall access all or any part of the system to build a product or service which competes with the system or undertake similar functionalities to the system.
So for the system, what I believe and what I know, when we have any concerns with the system, we are taking charge. We are addressing all the concerns that the system has, and we are ensuring that they have been incorporated, including the issues of corruption and ensuring transparency. And what I'm assuring you, Ashley,
Yeah.
let us have the PS Medical Service address all the questions that have been there with the AG, and have a comprehensive discussion about that.
Okay, I want us to take a short commercial break, but we'll be back shortly. Welcome back, and thank you for staying with KTN Prime. We continue with our conversation on the state of healthcare in this country, and joining me, of course, she's still here with me, CS Dr. Deborah Barasa. She's the CS Health Ministry in the country. So, of course, before we went for that particular break, we talked about this digitization system and what was in the Auditor General's report. So, another thing that has caught Kenyans off guard and they're interested to know is whether their health data is protected.
Yes, I want to assure Kenyans that their health data is protected.
But it is in the hands of private entity.
It is protected, and we have involved the Data Protection Agency. And data is critical. Data, is when we have data-driven results, when we are looking at data, we are able to make, tangible decisions and get tangible results.
Okay.
For time immemorial, we've been having people, using paper, and now we are going paperless. And what that does is that we are able to identify or have disease surveillance. We are able to know what is the prevalence of the disease burden of certain communicable and non-communicable diseases. We are able even now to preposition to quantify commodities with regards to this, you see. So it has been a challenge, and that is what has led to corruption. We'll be able to guide even the governors, on what medications, what human resource for health, etc. that they need to have. It's going to be used even as an advocacy tool. Yeah. So what I want to encourage Kenyans is that let us embrace this, because this is the way to go. All the countries are going that way. The interoperability, the efficiency, effectiveness, transparency, and accountability, and that is really what I like, because, with corruption, things are hidden in those papers. But when we have transparency and accountability, we always share this with even some of the private facilities and even public facilities. They're able to see.
But how assured are you?
Yes.
Because this is a private entity that has data of all Kenyans. How sure are you it's safe?
It is safe because we have passed it through the Data Protection Agency, and we are confident that our data is protected.
So then are you rubbishing the Auditor General's report?
Now, I'm not in a position to say that, but what I can assure you is that responses were given to all the concerns that she had raised, and what I can assure you, Ashley, is we'll have our PS to come and address all those things exhaustively.
What is our fallback plan now that we cannot even tweak the system? In the case where this system collapses, anything can happen. This is technology at the end of the day.
We are tweaking the system, actually.
How? Considering there was that clause in the contract that we cannot be able to.
So we are reviewing and, configuring and customizing it to our setting, all right? So that is what we are doing. Yeah?
Elaborate, because from that particular quote that I read just a few minutes ago, we are bound by a contract. We cannot tweak the system.
Okay, we are. And so what maybe what I'm saying is the PS Medical Services can come to discuss further. But, whatever system comes, you need to customize it to meet what your country needs, yeah? There could be language issues, the dates, the diseases. We need to customize the terminology. Our healthcare, like for the registers for facilities, again, we may use different codes with them, okay? How we are using the names. We have other platforms like the ICHIs. So customization definitely occurs for any system that you're using, yes.
Okay. Let's talk about the issue of contributions and ensuring that people register. What are the other means that we're using to lure in Kenyans? Convincing, because majority of Kenyans right now do not feel like SHA is the way to go. For those, should I say, the sheep that have been left behind, what are you doing to ensure that they are on board? Yes.
So it's critical that all Kenyans register. We need to really talk about that, and including the informal setting, because we see the formal setting are onboarding, but then informal, again, there's a bit of slowness. And so what we are doing is really working together with the community health promoters. So again, at county level, you know, implementation health is devolved. So the governors and the CEC, the teams for health within the county, and again, the community health promoters. And really, I must talk about the community health promoters. They have been able to visit 8.5 million homes out of the 12.5 million households in Kenya. And they've been able to diagnose more than 330 cases of diabetes and more than 331,000 cases of diabetes and more than 700,000 cases of hypertension. Equally being able to pick 134,000 mothers and taking them to facilities for care. And more than 6.9 children have been assessed under the community health program. So great work is ongoing. There's good coverage, and we are leveraging on this platform, that is the community health promoters, to ensure that they are informed, that they are assisting in a registry of patients, and also supporting them in order that they can contribute.
Okay. Now, according to the project consortium agreement, Apeiro will receive 57 billion shillings, Safaricom 21 billion shillings, and Convergence 17.2 billion shillings. Can you break it down for us? What exactly are their defined roles?
Okay. Now, that is an operational question. And it would go directly to the PS Medical Services, because each one of them was given a responsibility. Some of them were working on the SHA, e-claims portal, the SHA portal, and others were working on the registry, the health workers, and there was another team that was working on the patient journey. And so I apologize, I don't have those details, but given a chance, I can answer them.
Let's now talk about the funding cuts and how this has impacted Kenya in general and the health service. Now, of course, we're still reeling from USAID freeze. HIV mitigation programs, TB were some of those affected. How are we compensating for that as a country? And what is the extent of that implication of the aid freeze?
Yes, now I want to assure Kenyans that they are commodities at facility level. Tomorrow, Ashley, I hope you can join me. We're going to MEDS together with KEMRI colleagues and USG government representatives. And what we're going to do is, again, flag off medicines, flag off ARVs, anti-malarials, anti-TBs, among other medicines and commodities, so that they can reach facilities. And what I want to assure Kenyans is that for the next 8 to 9 months, we have medicines for Kenyans. Now, what are we doing thereafter? Because yes, they might continue lifting up, or again, they might pause. So as a ministry, we have sat in, and actually today we were with the development partners, sharing with them, seeing how they can support. Yesterday we were with the Council of Governors, together with the representatives from Treasury, and again, the program officers and technical officers, and what the PS and the DG, and what we were discussing is how can governors implement. We have established, we've come up with a report, and in that report, we are talking about the impact. We are talking about the resources that we need in matters human resource, in matters commodities. We actually even had, they had established a digital platform for various programs. So how do we integrate that into our digital health system, so that we have, integration and under one broader health system, which is Taifa Care. So those are discussions that are ongoing. We are sharing with Treasury. We have developed a CAB memo to share with the Cabinet. Again, for Treasury, we want to ensure that we are securing funds which will incorporate to support the commodities and also the programs that were being supported by USG. And what we are assuring Kenyans is we are working tirelessly, to ensure that we will not have a gap during this transition.
So this is within the 8 to 9 months, right?
8 to 9 months, we are comfortable.
Then afterwards, what happens?
Afterwards, that's where we are now securing funds from Treasury to support for the program to continue. But again, working towards integration of the program. What we are saying, we need one team, one plan, one budget, and one M&D. We've had fragmented, duplicated programs. Let me give you an example. Like for a HIV program, you have a truck with a driver. They come and take ARVs and they take to a facility. Then another truck with a driver takes anti-TBs and then takes to a facility. And another one, anti-malarials, to a facility. And you know, these, the partners are also in different counties. So you find that it's fragmented. But when we have it integrated and it's one, what does that mean? You can just have one truck and take all these medicines, all these commodities, and transport them, you see? So we have not had that, and that has led to inefficiencies. It has led to, it's not cost effective. It has led to loss of a lot of resources. And again, duplication, because anyway, a HIV patient can also have malaria, diabetes, TB. Does it mean that they go to another facility, you see? So it's all about integrating everything into one health system.
You did mention that it's a blessing in disguise. You know, it's high time we depend on ourselves. But how possible is it? And it's all about effecting it and implementation. Because so many people say Kenya is not short of ideas. The problem is implementation. So when you look at the long-term plan, when it comes to ensuring that we can cater for our own health services, what does that look like?
Yeah, being a doctor and working in a HIV program for more than 10 years, I understand. And you know, having worked for more than 10 years, I know we are over-dependent. We are over-dependent on donors when it comes to certain programs, yeah? And when the President, Donald Trump, had talked about self-reliance and self-sufficiency, that is a journey. And you know, when countries, when you're talking to partners and you're talking about sustainability, self-reliance, self-sufficiency, then there is that synergy. They want to push you forward. So the discussion right now, deliberations are not about the over-dependence. It's about how do we support you to be self-reliant. So that's the journey we are taking. So there is no turning back.
There's no turning back. I know, was it 2 weeks ago, the Ministry of Health officials were supposed to meet the US ambassadors to try see if there's a way that we can get aid in a different, maybe directive, not basically from USAID, but find another way of us getting aid. How far is that particular process?
Yes, we are engaging development partners and other partners to see how they can support us, talking to governments, having a G2G, private-public partnership, etc. But you know, I'm still focusing on that. Self-reliance and self-sufficiency is where the way to go. So this is just a transition process, yeah? But ultimately, what we are seeing, donor funds are dwindling, right? Right now, the focus is really, when you look at the partners, it's not about HIV, it's about security.
Yeah.
That's what people are talking about, and humanitarian concerns. So since the tables are turning, then we need to anticipate for whatever comes our way. And so as a country, we also have to come up with solutions that are reliable and that are able to support our patients. So during this transition, even as we look for donors to support us during the transition, what we are really emphasizing from National Treasury is resources to support our patients. Yes.
So in general overview, how does this affect Taifa Care?
Now, Taifa Care is again the answer to all these programs.
How?
We've had multiple programs. So when you look at HIV program, it's the same thing. You go to a primary health care, you're given ARVs, and if you complicate, you go to the higher levels of care where you're admitted. Under the Social Health Authority, the primary health care, we can have our ARVs under the primary health care fund, meaning each and every HIV patient can access those ARVs if you're positive, yeah, at no costs.
But we're currently rationing our ARVs. If
we are not rationing.
We
cannot ration ARVs. No, we can't. Yes. And we've had so much gains. I mean, we've had 98% of patients diagnosed, 98% treated, and 94% virologically suppressed. So great improvement in the HIV program. We don't want to lose the gains. So what we are emphasizing, we need those medicines at the primary healthcare level. Again, the challenge would be the human resource, but what we are looking at is the core human resource that we require to support in terms of management of cases, because that's a lot of knowledge that has been gained gained by these the staff that were working in the HIV program. So again, integrating them into the broader health system.
Okay.
Yes.
From a point of authority as the CS of health in this country, if you're told to define the state of healthcare, how would you define it?
First of all, I believe we're progressing well. When you look at the UHC, we've implemented the follows. We have implemented social health insurance with more than 20 million Kenyans, which is 3 times that which we had in NHIF, already registered, okay? They can access care, and they are getting affordable quality care. We've enhanced our cover to include other health benefit packages such as the ICU, oncology, mental health, among others. And again, we've improved accessibility and have complementary funds. We have the contribution through the Social Health Insurance Fund, but we have again National Treasury helping us with the Primary Health Care Fund and the Emergency Chronic Critical Illness Fund. So a blend of resources that can support us at any time. Now look at again the amount that we have, 2.7 surplus, you see? Meaning that if we have all Kenyans on board, then we'll have enough finances to support in terms of expanding health infrastructure. We've enhanced our PHCs. Previously, we're encouraging level 5 and 6 under NHIF, and especially the private were the ones who are benefiting. And you see that a bit of noise is because of that. Now we are encouraging primary health care facilities. I remember even the governors one time when we were having a meeting and they were saying, why is the private facilities having more money? And what we told them, now make sure that your public facilities get the same money, because once you're bringing your clients, the patients into your facility, they are registered, the resources will trickle down to the public facilities, and you'll be able to have human resource, commodities, equipment to support the people.
Okay.
Yes, again, there's a lot we've done.
Okay.
Yes.
So you have been at the ministry for what, around 5 months?
Yes.
How is the working relationship between different departments?
The working relationship is good.
Are you sure?
Yes, we are working well.
All right, I want us to just listen to something that happened just the other day at the National Assembly Health Committee. I believe we do have that particular bite, if we can play it.
It's not the first time we are not seeing the Director General here. In most of our meetings, he's not there. And what one would have expected is that there are technical issues where you may not even need to have all this. And our understanding that that is the office that actually coordinates all these programs.
So why is it that the health DG, Dr. Patrick Amoth, is never there?
No, Dr. Patrick Amoth has to be there. And you see how...
But he's not been there.
Yes, now next time we will ensure that he's there. And he has the institutional memory, he has a lot of technical experience, and he is my technical advisor, So we are really relying on him in matters of advising us on the technical issues and bringing both state departments together, because you will notice that there are certain things that crossover. When we are rolling out UHC, some are in one state department, others are in the other, like primary health care and the community health promoters are in public health. And yet we have SHA, we have our digital health and other programs, the infrastructure, the NASPAR, under medical services. So the synergy, the harmony, the teamwork is really critical for UHC to be success.
Then one would assume, considering you're saying he's your technical person, when it comes to such, an issue, when it comes to a committee, he would be there to help you answer a few questions. So what viewers are asking is, why hasn't he been there?
Now he'll be there. Next time you'll see him there.
Finally, as we conclude your parting shots, as we conclude.
Yes, my parting shots, I want to assure all Kenyans, Taifa Care will be a success. We are very privileged and lucky to have His Excellency, our President, Dr. William Samoei Ruto. He's the champion of Taifa Care. And we believe that once it is implemented, we'll have accessible, affordable, quality care for all Kenyans, no matter your age, no matter your tribe, whether you're rich or poor, you know, whether you're disabled. Each one of us should be able to access services whenever we need it. And so we are working tirelessly. People are, you know, people are ensuring that they are working to ensure that patients are able to access services. Yes, we have had challenges, but I can assure you, Ashley, right now the system challenges have really marvelously reduced. I talked to Lishenga recently and I told him, how is the system right now? Ask your people. And he told me that yes, we are doing well, the system has improved, and again, we just need to work on this and that.
How far are the claims?
The claims we are paying. So there was just a few of them that needed to undergo claims management for review. But most of the money we've been able to pay.
Okay.
Yeah. The only challenge is the facilities which have not given the right name and the right account number. So what we're encouraging the healthcare facilities, please review, see if your facility name is there, and if there is no money you've received so far, please reach out to our SHA team. We will work, we have the call center, we will work together to ensure that the money is released to you on time.
All right.
Yes.
Well, I do hope, as you've promised, that there will be a comprehensive report, and the PS will be coming next week,
Absolutely,
Thursday.
absolutely.
So we consider that booked.
Booked.
All right, thank you so much. That is Health CS Dr. Deborah Barasa. They're just telling us where we are at when it comes to the state of healthcare in this country. And that's how we wrap things up here on KTN Prime. Thank you so much for making time for us. On behalf of Jesse Rogers, Amerisha Wheaty, and I, have a good night.